So coming to the spirometry. So spirometry is very commonly used. It's one of the most commonly used pulmonary function tests. It's very easy to perform and you can just do it in your OPDs as well. There are two ways in which you can do a spirometry. One is you ask the patient to inhale, take a deep inhalation, and then insert the mouthpiece and then forcefully exhale as fast and for as long as possible. And then the system measures the air. Or else there's also another way wherein a mouthpiece is inserted and the patient takes several normal breaths and then the airflow gets measured. So there are two ways of doing this, depending on the machine and depending on the spirometer that you have. So what does a spirometer do? It basically assesses the integrated mechanical function of the lung, the chest wall, respiratory muscles, and the airways by measuring the total volume of air exhaled from a total full lung to maximum expiration. So basically the journey between the total lung capacity to the residual volume. That is what is measured in a spirometry. So what all we measure, it is the FEV1, FVC and FEV1 by FVC. So this is what a spirometer might look like. So we have a few acceptable ATS, American Thoracic Society has a few things that we need to have in mind before we say that, okay, what the PFT that we conducted is acceptable. So we have to do, we cannot just do one blow, like the patient cannot just blow air only once. So we have to repeat the test at least 3 times. And we need to see if two of the largest values of FEC have to be within 150 ml of each other, and the largest values of FEV1 also have to be within 150 ml of each other. If both of these criteria are met, then we can say that the test is done. But suppose if the difference in the readings of subsequent spirometer readings is more than 150 ml, then you will have to continue to test till this criteria is met, or till you have done a total of 8 times, till you have tested a total of 8 times, or if the patient is not able to continue. If you are able to get the values well, then 3 readings will be the minimum. So this is how we interpret the the spirometer reading. So maybe we can just ponder a little bit on this slide as well. So the normal values, they depend on the height, age, gender, and ethnicity of a patient. So it's not the same for a 20-year-old male and for an 80-year-old female. It differs with gender, differs with age, their height, weight, and all of those things. So like I said, FVC, FEV1, PEFR, PEF 25 to 75, and FEV by FVC. All of these are measured in a spirometry reading. I will be showing you a sample spirometer reading as well, which will give us an idea as to what it looks like. So normally any reading which is above 80% is normal, and a mild decrease is when we say when the values are around 60 to 80%. Moderate is when it is between 50 to 60%, and severe when it is less than 50%. So basically, we concentrate on FVC to look at restriction and FVV1 to look at obstruction. I will tell you why it is like that as well. The other thing is we also look at a positive response to bronchodilator. So we do a spirometer test. We give a bronchodilator, either a nebulization or a puff, like an acid nebulization or something like that. And then we repeat the test. And again, here we look at how so there has to be an improvement in the bronchodilator response. So if there is a positive response, like FVC is increasing to greater than 10% of the previous value, or if FEV1 is increasing to 15% over the baseline, or if FEF 25 to 75 is increasing to 20%. So any of these things, 2 out of these 3 things, if it is positive, then it is called as a positive response to bronchodilator. And this is something that helps us in diagnosing and monitoring of especially bronchial asthma. So going to the next slide, let's look at the type of respiratory disorders. Any idea what are the 2 types of respiratory disorders?
So I request all the attendees, can you please write about the 2 types of respiratory disorders, the names of it in the chat box?
Yes, yeah, I think somebody mentioned Vikashini, obstructive and restrictive. Yes, that's very good. So we have obstructive respiratory disorder and we have a restrictive respiratory disorder. So this is one thing that helps us in interpreting a pulmonary function test. So what happens in an obstructive pulmonary disorder? Examples of obstructive disorder is asthma, bronchitis, emphysema, cystic fibrosis, all of these things. So basically the airways are narrow. So air enters the lungs, but because of the narrow airways, it is not able to move out of the lungs. So expiration becomes a difficult thing to do. So there is a lot of airway resistance because of bronchospasm and inflammation, and the air is not able to move out. So what happens here is the FEV1 is reduced more. FVC, which is the forced vital capacity, is also reduced, but then mainly the FEV1 comes down in an obstructive disease. And the FEV1 by FVC ratio is less than 70%. But in the restrictive lung disease, what happens is the lung volume itself is reduced, or the lung compliance itself is reduced. So basically, like for example, suppose there's a lung resection, or there's a pulmonary fibrosis, or any connective tissue disorders like scleroderma, sarcoidosis, or obesity, there is no enough space for the lung to expand at all. So basically what happens is the air flow even within inside the lungs also reduces. And hence there is a less amount of oxygen that goes into the bloodstream because the size of the lung itself has sort of reduced. So here what happens is the forced vital capacity itself is reduced. So that is why FVC gets reduced more than FEV1. But then the ratio, when we look at it, it will be more than 70%. So this is the main difference between an obstructive and a restrictive disease. In an obstructive disease, the ratio is less than 70 and FEV1 is reduced more. In the restrictive disease, the ratio is more than 70 and FVC is reduced more. So when you look at this, that's what I've put in the table as well. FEC will be normal to reduce in obstructive, but it will be reduced in a restrictive. I think it's the same thing, whatever I've just explained. So we'll look at some examples as well later. So also we have something called as spirometry curves. So what happens in a spirometry curve? So, so is this a normal curve or is it an abnormal curve? Any ideas? Yeah, so Nurul has said that this is a normal curve. So basically, when you look at a spirometry curve, we have the FVV1, which is the first second, the air expired in the first second. And then by FVV3, it sort of, reaches almost 100%. And you have the total forced vital capacity as well. I don't know if we have an option of using maybe I can just spotlight or something. Okay. Yeah, so if we can look at this, so this entire thing is the forced vital capacity. And then we have the FEV1 here, which is the air that moves in the first second. And then by the third second, it sort of reaches a plateau. So this is what happens here. So this is a normal curve. So what happens in a restrictive or an obstructive thing? So what kind of a curve do you think this is? Is this an obstructive curve or a restrictive curve? Can we have any answers? Is this obstructive or is it restrictive? Okay, Arijit says it's obstructive. Nurul says it's restrictive. Okay, so restrictive. Okay, we have answers to both sides. Okay, so so basically, this is an obstructive curve. So what happens is, let's say, okay, let me show you the other one. So this is a restrictive disease. So let me just show you what is the difference between both of these. So what happens here is, so this curve that you see is the normal curve. This entire curve is the normal curve, right? So in an obstructive disease, the air entering is also less. At the same time, the air that the patient is not able to exhale out the air fully. So FEV1 is the forced expiratory capacity, right? So the patient is not able to expire fully. So basically what happens is his curve is reduced like this. So right from the beginning is FEV1 itself is reduced. But then in a restrictive disease, what happens is the entire forced vital capacity itself is less. So it's supposed to be so much, but then it's only so much. But then the FEV1 is normal compared to the FEVC that is there. So that is why the ratio here will be more than 70%, because compared to the FVC, FEV1 is, mostly normal, or it is increased. So that is the difference between the obstructive disease and restrictive disease curve. So this is what it probably looks like, a normal curve. So when you look at a normal curve, you'll be able to make out. In an obstructive curve, right from the beginning itself, the curve will be slanted, and of course FVC will be low. In a restrictive curve, initially the FVV, the part of it will be fairly okay, but then the FVC itself will be reduced. So let's also just look at just give me. Yeah. So let's also just look at the flow volume curve. So this is also another thing that we get to see in our spirometry readings. You might have come across this. So basically flow volume curves are produced when a patient performs a maximum inspiratory maneuver and then followed by an expiratory. So basically when a patient inspires and then expires. So the negative limb of this graph, if you can look at it, that is the inspiratory limb. And so yeah, okay. So this is the inspiratory limb, if you all can see, and this is the expiratory limb. So this is what we see. And then it also talks about the, when you're expiring, there is a FEV1 and then F 25% and 75% as well. So a graph is produced with a positive expiratory limb and a negative inspiratory limb, and it also measures the peak expiratory flow rate at FEF 25 to 75%. So for example, this is what a normal volume curve looks like. So you have a positive negative inspiratory limb, and then you have a positive expiratory limb. Can you tell me what this probably is? Is it obstructive or restrictive? Okay, so we have answers saying this is obstructive, COPD obstructive. Yes, COPD is an obstructive disease. Okay, so so this is basically an obstructive flow volume curve. So what happens here is there is a reduced expiratory flow in peripheral airways, and hence you have a concave appearance. And this is a respiratory, a restrictive disease. So what happens in a restrictive disease is the entire lung capacity itself is reduced, right? So FVC itself is reduced. But then because FEV1 is almost normal, you have a long elongated sort of a curve. So the flow rates are preserved, but the volume itself is reduced. So the expiratory limb will have a convex appearance. But when it comes to an obstructive disease, it will have a concave appearance. We also have something called as an intrathoracic large airway obstruction, wherein the expiratory limb will be flattened, but then the inspiratory limb will be preserved. So we usually see this in a bronchial tumor or in a tracheal tumor, because inspiration is happening, but then expiration does not happen. Because of an airway obstruction. Sometimes there's also an extrathoracic airway obstruction. So here what happens is, in an extrathoracic airway obstruction like a vocal cord paralysis or a tracheal stenosis, there will be a flattening of both the inspiratory and the expiratory limbs because of a limited airflow.